Hello and welcome to the Health Odyssey podcast, episode 140. If you are listening in the UK or probably anywhere in the world, you're aware. I've just been reminded by Mr. Peter Lant that tomorrow is the coronation of King Charles in England. So that's tomorrow. So if you're listening on the day of release, which I'm sure you are, so I'm sure you will subscribe and wait with bated breath till the episode is released every Friday. Tomorrow is the coronation of King Charles. So congratulations to him. And I'm sure everyone will have a lovely weekend in the UK, whatever they are doing. Anyway, we have a fantastic guest with us today for episode 140, who I will introduce you to in a minute. But first of all, I'll check in with the usual hosts. We have four of us here today. We have the three usual hosts and our guests. So, Mr. Peter Lant, how are you doing?
I'm doing outstandingly well today, actually, because I went on a massive walk with the boy yesterday. Because I do on a Wednesday when the weather was lush, so we're out for like 5.5 hours, and then I had a cancellation this morning, and nobody had booked in on the earlier session as well because of like the way it's gone over Easter and stuff like that. So I've been out for a 10-miler with him today as well already. It's fantastic.
Wow. I thought you were going to say you had a big lie-in.
No, I had a bit of a lie-in. I was like editing videos and stuff like that because I edit the podcast actually on a Thursday morning sometimes. And I was editing videos and what have you because I found a new video thing that I can edit and subtitle and shove memes in and all that sort of stuff. It's great. But anyway,
I think I've seen that on your Instagram actually. Yeah, when you talk.
I'm quite excited about that actually, which is very sad.
You're going to be a real official influencer soon because I see.
Really, I record videos all the time for my group on Facebook, and I'm like, well, I can chop them up and use them. So I've been doing that. So it's already all there. I just use it. So I'm quite excited about that because I feel quite clever.
Excellent. And Mr. Paul Bassett, how are you doing?
Oh, bad. Pete's had a few close calls with his back, hasn't he? Because you know, your form. I mean, so many comments. I mean, where do we start with that back position and your pressing position? You're just wait. I'm just saying.
I know.
You're just waiting for your back to explode.
Well, if it's going to happen, it'll happen at some point, won't it?
Yeah. Well, Peter's been inundated with a few little trolls.
Yeah.
Oh, it's good that you're kindly teeing up the guests that we have with us today, which is good. I don't know if that was intentional, Paul, or.
Well, I'll take the credit.
Okay. So today we are joined by Dave Adkins from Principle Physiotherapy. Welcome, Dave. How are you doing today?
Yeah, very good. Thank you. Thanks for bringing me on.
Excellent. So, Dave, I have known for, a long time, probably over 20 years, I think, all in all, through kind of some social circles and mutual friends and that sort of thing. And Principle Physiotherapy is actually physiotherapist that is homed within Unique Results in Chelmsford in Essex, and also does physiotherapy in the surrounding area as well, and some visits and some outreach stuff as well, and working in a few other clinics, I think. But Dave will tell us all about that in a bit. And it's always interesting for us just to speak to fellow fitness professionals, fellow health professionals, people who are working within the same sphere as us, albeit coming from a slightly different angle, just to kind of find out their background, their experience, the way they run their business, their views and philosophies on maybe training, rehab, prehab, injury prevention, all this kind of thing. So we thought we'd get Dave on today to kind of find out a bit about him and his history and career so far and what he does. So Dave, I suppose, first of all, do you want to kind of share maybe your background story with us in terms of, how and why you got into physiotherapy, what your route into that was, your career pathway so far up until now, and I suppose kind of, the decisions that you've made along the way, and the kind of beliefs and principles, and you're obviously called Principle Physiotherapy, the kind of beliefs and things that you've found along the way that sort of got you to where you are today, if that's okay. And we'll just jump in and ask questions along the way, if that's okay with you.
Yeah, that sounds good.
Perfect.
Okay, so if I was to start right from the beginning, I was really just fascinated with football. I'd play football and watch football. So over a few years, when I started out, I was picking up little injuries, and that was when I was first introduced to physiotherapy, and using exercise as a way to fix little issues that I had. Going into like the later years of school was when you had to start picking what you wanted to do, and one of my main topics that I enjoyed was PE, and the science as well, like human biology. So it just seemed like that was the best route for me to go down, really, because I was thinking maybe I'd get into being a football physio, and then obviously later on that wasn't to be, but that was my first interest, and I just wanted to be in and around football, really. So that was my first real reason for getting into physio. I would say once I left college and I did a sports massage course, I wasn't using that too much. I ended up going into retail and spent a bit of time just working there. And it wasn't until I got a job at Great Ormond Street Hospital that I decided to get back into physiotherapy, and I was a physio assistant there for 3 years.
So how was that then, working at I didn't actually know that. I mean, I've known you for a long time, but I never knew you worked at a Great Ormond Street. So that's obviously working with children in London. Yeah, tell us a little bit about that. Kind of what kind of conditions were you working with there? What was it like working? Because Great Ormond Street's obviously globally known, isn't it? Across, everyone, a lot of people in America, and I know it's with its links to kind of Peter Pan and that whole story and the fundraising behind that. Great Ormond Street's one of the most famous hospitals in the world. So yeah, what was that like, and what was your experience like there?
Yeah, I got really lucky getting in there, actually, because I applied for a physio degree part-time, and they said that I needed to get some experience. So I started applying to local hospitals, and they were asking for experience as a physio assistant. So I was hitting a dead end, and then I applied for Great Ormond Street, and for whatever reason, they wasn't expecting experience on your CV before they would interview you. So I got offered a job in rheumatology, and in Great Ormond Street Hospital, rheumatology mainly covers things like childhood arthritis, some rare conditions, but there was a large bulk of people that were there, or children that were there, that experienced issues with hypermobility. And that's probably the most common sort of condition that people might have heard of as well, because people might call it double jointed. And there's different types of hypermobility, and they've got a special term called Ehlers-Danlos syndrome. And that is like an overpinning of different conditions with issues with connective tissue. So people that had extremely flexible joints would have real issues with getting started with walking as babies, and each milestone was quite challenging for them. So that was why we would have those children into Great Ormond Street. But yeah, you had really rare conditions that you would never hear of unless you were there, like juvenile dermatomyositis, which was a really interesting condition that when a child experienced it, they would lose control of their sort of central muscles, so your core and your neck. So they'd go from being able to be functional, and then they'd lose all of their strength, and they wouldn't even be able to lift their head up. But the great thing was, through medication, that would really help them quickly, and then they would come to the physio department, and we would start to rehab them and get them back to where they want to be. And it was great because I ran a 2-week intensive rehab program where children would come twice a day, and you would just run through exercises to help build their strength and fitness, and then they'd be discharged at the end, hopefully back to school and back to normal life.
So through that period, then I presume if they're coming in twice a day, they're inpatients in the hospital there, are they? And they're staying in the hospital the whole time and just coming in twice a day to see you while you're there, yeah?
Yeah, so there was children that were on the wards, and they would be brought down by either the ward staff or their parent might bring them down. But there was also a hospital hotel, and children that didn't need to be medically looked after, they would stay in the hotel and then come down to the gym twice a day. There was a school at the hospital as well. So in between the gym sessions, they would go off to school, and whatever level they were at, they'd be getting some support with their schoolwork.
Wow, that's fantastic, isn't it? I mean,
That's amazing.
Yeah, it's incredible. I mean, I know Great Ormond Street is like a globally renowned hospital, a children's hospital, but to think that there's a hotel attached to it, there's a school within it, there's, these gyms, there's everything there to look after the children that's really incredible. Were you going to say something, Paul? Sorry.
Oh, no. I was going to say, no, my brother went there when he was 2 in the early 80s, and because he had leukemia. He was fine, he survived. But it was really supportive. I remember my parents going there all the time for months on end. And it was a very supportive environment, particularly he was so young. I'm sure it's no different now. There's nothing quite as stressful, I think, as a parent when your kid's ill.
I'm interested in the hypermobility stuff, because we've spoke about this sort of stuff before. Like when people can move but they're not very flexible, and the desire, they really want flexibility and they want to stretch everything, but actually there's people who've got too much flexibility and can't control it. So how? I don't know what my question would be, actually, because there's so much, isn't there? But if it's quite, that's quite interesting that, like, if you've got it from birth and you're struggling to just maneuver, to crawl and walk because your joints can't support you and you can't actually build that functional strength, for want of a better term, I suppose, but that strength from a baby. I mean, people struggle with that when they get older, don't they? But that, like, how do you deal with that? What sort of stuff? What sort of stuff do you do? Because you can't get them to lift weights or anything, can you? That's the thing. You know what I mean? You got to get them to somehow try and move.
Yeah. So there's basically a spectrum of people from one end that are really too stiff and they really struggle with movement. So it's people that have this incredible amount of flexibility in joints, which then can make them disabled because they can't actually control their joints. And when you were talking, there was a picture of a young girl that we used to see that had incredible flexibility, but all of the simple things that we would all take for granted, she found difficult until she built up her strength. And I think she was 4, and she'd always come in for like 2 blocks of 2 weeks at a time. And we would follow the same program twice a day, and you'd start off with no weight at all, and you'd be doing things like straight leg raises, sideways leg lifts, bridges, hip extension exercises. And each day, as they got better at the exercise, you would start to add small ankle weights. So we'd have loads and loads of ankle weights for all the different ages and strengths. And you would slowly build up their strength by using a 1.5 kilo, 1 kilo, 2 kilos. And there's kids that are up to 5 kilo ankle weights at the age of 7, 8 to 10. This young girl had the biggest quads I've ever seen in a child that young, because you just don't get definition in children. But because she was having to build up muscle to make sure that she could stand and she could walk, get up from the floor, she had like the most defined quads, and she was able to do things. And once we built up the strength in her, she was able to do everything everybody else was doing, but also she had the ability to do things that nobody else could, which was like becoming a contortionist. And it was fascinating what you saw there. But she basically just went from having no strength to following a strength program, would come each year, and then she could build muscle like anybody else.
But with a contortionist, is there, I mean, that's a very extreme range of motion. So with a contortionist, you've got a very extreme range of motion. What makes that safe versus hypermobility? So, for example, like I've got clients who've got hypermobile and they can quite easily injure themselves, but in no way do they have the range of motion of the contortionist. So what's the difference if someone's thinking about the injury scale? What's going to take someone, because obviously you get circus performers who do it day in, day out, or who've got very high levels of range of motion. So what's the difference?
I think I just have to go back to like the spectrum, really, in the sense of this young girl was on the end of one of the spectrum, and the people that we see day to day, they have degrees of hypermobility. Some would have been given a medical diagnosis of hypermobility syndrome or Ehlers-Danlos, but the injury will really come if the joint is loaded beyond its ability. So someone with hypermobility won't naturally have more chance of injury if they perform exercises in the right way, avoid falls and like heavy falls or things like that where they're out of control. But the key thing is having the right amount of strength. So if you're strong enough to withstand jumping and twisting and turning, you're no higher risk of injury than somebody that doesn't have hypermobility.
So if someone has hypermobility, they've got hypermobility and they're going to have hypermobility. If they get stronger, they can then control that, but it is still there.
Yeah. So
yeah,
in children, a lot of children have a degree of hypermobility where they're a lot more elastic and their joints are a lot more mobile. Boys tend to get stiffer joints as they get older, so they don't maintain the same amount of hypermobility, whereas girls generally will continue to have a high degree of flexibility in their joints. But if you're hypermobile, you'd have that into your early adulthood, you'll have that for the rest of your life, unless you as you get older, you get arthritis, and then that will obviously restrict movement.
Yeah, I just love what you said about like that. Then she could use it to her advantage. Like once you learn to control it, it's like right now you can do things that other people can't, and I love that, because that empowers somebody, doesn't it? Especially at a young age. It's like, you know.
Yeah, and that's one of the issues, is that people believe that once they're given a diagnosis, that will be a problem for the rest of their life. But with any diagnosis, if it's managed well and you get the right support around it, then people can live pretty normal lives. With hypermobility, it sometimes becomes a tag that people can't shake off, whereas actually it can be an advantage if you strengthen up, stay healthy, and maintain good quality joint health rather than overly use it, which everybody can do if they overtrain or play too much sport.
I was just going to ask, I know we're kind of talking a lot at the moment, and you haven't even been and got your physiotherapy degree yet in terms of the timeline we're on. But it's kind of quite an interesting discussion in terms of you mentioned sort of boys and girls there. I'm wondering what the kind of what the percentage is of kind of nature and nurture with this, because I mean my daughter Bella is 6 and she does loads of like dance and gymnastics and things like that, and boys tend to like you said, your background, go into things like football and maybe rugby and stuff. I mean, are girls, is there a natural, girls as they become teenagers and become women, are women biologically more flexible than men, and the men are biologically generally stronger than women and maybe stiffer? Is it because girls do a different type of sport as they get older and men tend to lean towards a different type of sport, or is there a real biological difference there, do you see, with boys and girls as they start to get a bit older?
I would say that there's definitely a difference in biology, which means that men, when boys grow and become men, they have different changes that make their joints stiffer and more muscle bulk. Also, you'll find that people that have the advantage of flexibility will likely go into different sports and different activities. Like rugby players would tend to be a bit more solid. A really flexible gymnast wouldn't last 2 minutes in a rugby match, so they might shy away from that becoming their discipline. And vice versa, someone that is naturally quite stocky and doesn't bend too well, they might stop doing gymnastics after a couple of weeks because everybody else can do things that they can't. So I wouldn't say that the type of exercise you do will generally change how much hypermobility you have, but you might end up seeing differences in girls and boys because of biology.
Yes, you kind of almost you play to your strengths, you know what I mean? You kind of you stick to what you're good at and you avoid what you're not so good at, and then that just kind of exaggerates that as you get older. Yeah, cool. Yeah, so from Great Ormond Street, so you've gone there and been working there to gain experience and all the rest of it. And then what was next for you on your kind of career path?
So after a few years there, I applied for a foundation course, which was like a global sort of sciences and skill set to get you to the level you needed to go on to university. Went to Brighton University and did my degree there. And then once I completed the degree, I moved back up this way. And that was when I contacted you. And that's when I popped into the gym and just found out if there was an opportunity for me to start bringing in my private clients alongside working in the NHS. And that's when I started working at Basildon Hospital. And I think I started in orthopedics. And then I went on to stroke. And then after that, I knew that my speciality was going to be musculoskeletal, and that's when I went and worked in musculoskeletal departments, outpatient departments, ongoing from there.
Okay. So, and how did you find working as a physiotherapist in the NHS? You know, what was that? What was that like in terms of the care you were able to give and I mean, I suppose a benefit is that you're exposed to lots and lots of people within the NHS, but so you're exposed to lots of different types of people, different types of problems and issues, but how was the experience of that for you?
I think it was really, really important that I did that first, because it gave me an understanding of lots and lots of different conditions that if I went straight into private practice, I would not have been exposed to. So then your knowledge isn't high enough to be able to identify different problems. You also have the benefit of having a team. So you'll have senior physiotherapists and physios that will have had gone on to different courses and had lots of professional experience, so they could teach you along the way. And I think that the real downfall really for the NHS, which I think everybody knows, is their ability to see everybody enough. Because quite often the goal of the hospital is to discharge people as early as they can safely. So that will just limit the amount of time that we would get to spend with any one patient and help them get back to where they need to be. But obviously the reason why the NHS is there is to help people survive and then help people get home well enough to be able to continue. But unfortunately, there's just too many people, not enough staff, not enough beds. And then one of the bigger problems is the social care outside as well. So people are not able to be discharged until something becomes available outside. So there was so many barriers to providing better care, but there was so many positives as well for me professionally, because as I say, I got to spend time with really experienced and advanced physiotherapists and nurses and doctors.
That's really interesting, because from my point of view, if like something happens with someone who I'm training, like one of the guys at the minute has got a sore knee, and he's had an ACL replacement years ago, and he's in his mid-50s, been training for years, he's squats, everything absolutely fine. The thing is, he's had a bit of stress in his life, and then all of a sudden his knee's sore again. So I was like, right, hang on, can that be related? All that, I don't know. But he's just said, oh, I'll go and see the doctor. And I'm like, what would you say in that situation? Because is the doctor, is it right? Is your GP the person to go and see? Because, he could afford to go and see a physio to get a diagnosis from them. And because I said it would be good to go to see somebody, obviously, to get, to either get a diagnosis or just get peace of mind that it's nothing that is gonna stop you walking or anything like that. Do you know what I mean? So what would you say in that sort of situation? Because obviously you go and see a GP, you might get referred to an NHS physio, and then that's fine. But I was going to actually ask you the question: how long do you spend with them within the NHS? Because obviously, like you've said, it's going to be a certain amount of time, and you're going to get them to a certain point. But then that's how much money there is, isn't it? And it's.
I suppose you might wait weeks for a doctor's appointment.
Yeah.
You might wait months for a physio appointment, especially if it's for like a sore knee, which is not a priority and not stopping you.
Yeah,
it's not. Yeah, I don't know what. Yeah, Dave obviously will be the person to,
But I mean, like general population type person goes, oh, I'm a bit sore somewhere, I'll go and see the doctor, and it's like I think that adds an extra layer of waiting and like maybe allowing the problem to get worse or just prolonging your discomfort. Do you know what I mean?
Yeah, I think that going to a GP for the first point of contact is never a bad thing to do, because they will be able to refer you to the right person. Because of the backlog, you don't get to see the next person for a long time. So a lot of people are starting to seek out private physiotherapists first, because there's no waiting time, or there's minimal waiting time. And I would say whenever you have an injury, you would probably be best going to see a physio or some kind of therapist. I wouldn't say that just physios, there's osteopaths and different therapists that have that knowledge of the musculoskeletal body, rather than going to a GP, because the GP is good at signposting, and they can also give you medication or advise you on medication, and often it's rest. And with any one injury is different, but often rest is only something that you do within maybe the first 48 hours. And then the next stage is trying to work out how much load is safe and how much load is optimal to build you back up again to whatever activity or sport or work or anything like that you're doing. And physios are obviously really well placed for that. So I would say, if you can, go and see a physio. If it's not possible, then going through the GP to see a physio in the NHS. Well, I was quite lucky that when I was working in outpatients, I'd get half an hour with any one patient. I'd be able to book them back in. There was maybe a guidance to see people for maybe 4 sessions on average, but there wasn't any pressure above while I was working there not to see them more. So I was able to keep seeing people as long as I needed to. But there was some protocols in place to try to reduce numbers of sessions, and also discharge some people on their first session if it was a mild issue. So there is limiters, but at the time I was working there, I was able to see people for longer than what maybe the average physio might do in the NHS. But funding is obviously being restricted, and less physios are there. The waiting times have gone up massively. People are waiting 3-4 months. So any acute or subacute injury is becoming a chronic problem. And then once it becomes chronic, then it's normally more complicated to manage, because there's lots of psychosocial issues involved as well, where maybe the injury itself it could have been dealt with quickly and effectively, but people tend to have, the longer they have a problem, it starts to affect their lifestyle, it starts to affect their family, their work, and then that's when things become a lot more complicated.
I suppose. Yeah, sorry, Paul, go on.
I was about to say, no, you talked about like that within the 48 hours of an injury to start doing things. I mean, we've had another guest, Mark Rifkin, on a podcast who's had knee replacement. He was pretty much the next day after the operation being taken through a lot of the kind of movements that would start that healing process. And it was, from what his description was, it was incredibly painful, but very necessary to do that. So, I see a lot of people, and you just mentioned it a second ago, some people have lived with these things for a long time, aren't they? People's capacity to deal with a low level of pain, or even a high level of pain, back pain, knee pain, whatever, they can kind of live with it or accept it. What are you suggesting that people do? I mean, what's a good kind of like how should people kind of manage the process? Because people come to us and grumble about injuries all the time, but it's not necessarily something that they always need to act on. So what is your general advice?
So if someone's had an acute injury, so an ankle sprain, or they've had a fall and twisted a joint, or they've pulled a hamstring, then the process tends to be quite a linear process. You'll give it time to settle down. You'll ice it regularly within the first 48 hours. And even that is a bit contradictory these days. There's lots of people or research around whether that actually hinders the initial inflammatory process. But typically you're advised ice, rest, and then within 48 hours, you want to start trying to load it in some way. And that's normally guided by how it feels. So if you've got excessive pain trying to walk on it, then you might need some aids initially to help you load it through walking, so crutches. Other ways to load it would be doing simple range of movement exercises, and then some gentle strengthening with bands. Until that person is able to walk without crutches or able to walk normally, you wouldn't really want to be progressing on to anything more advanced. And again, it's all guided to how the body responds. So if the ankle suddenly swells up, then you know that you're likely to be overloading it. If their pain is going up, then you're likely to be overloading it. So you have to try to be patient with how the body's healing. Age is going to be a factor with that as well. So for each individual person that comes in, the process will be slightly different depending on if they have injured the same place before, if the severity of the injury, their age, any other comorbidities. But typically you'd be looking to gradually build their mobility back to their previous state. The trouble is that you don't, especially private practice and in the NHS, you don't see people with acute injuries because they're quite good at managing them. You see people with long-standing back issues or long-standing joint issues through overuse, and maybe genetics has caused them to develop some arthritis, and that becomes more complicated because, like you said, some people you'll be training and they will have back problems for the last 20 years. So you have to try to manage their flare-ups. You have to try and work out what exercises will help, what exercises are likely to flare it up as well. From week to week and month to month, they're going to have different stresses outside of training. So that could be work, that could be home. All kinds of aspects of their lifestyle are going to impact their back pain. And what you can do is guide them to understand what are the triggers.
Because I think that kind of going back to the initial thing about when you have an issue, what would be the first port of call, just from working with people for 25 years now, a lot of general population, if they have something wrong with them, I think whatever that might be, to whatever severity, and it's different for everyone, I think there's this kind of almost inbuilt, and it must be a learnt response, that if you have some kind of pain or some kind of injury, the best thing you can do is rest, and just kind of do nothing and just try and allow yourself to recover. And the one thing that's a bit worrying is if, for example, you did have to wait 3 weeks for a GP's appointment and then 2 months or 3 months for a specialist appointment, a lot of people would just do nothing for that period of time and it's not they don't know. Probably the fear is that if I do something, what if I do the wrong thing and make it worse? I suppose that's probably people's in people's minds. So I think that I don't really know what the question is or what the answer is, but it's that kind of, I think I know from dealing with you and from knowing you for a long time, and from the way that we work with people and through our own training, I think if I'm injured in some way, but I can still do something else to kind of work around it and still be mobile and still have some form of exercise and movement, then I'll try and do that. But I think the general population, it's almost like that kind of do no harm is almost taken to the extreme, whereby I'll do nothing until I get a cast iron diagnosis or I get told what to do. I mean, when you see, it's different for you now because you see people privately, and people, like you say, they book in with you and probably within the next 7 days, they'll get to see you, or next 7 to 14 days. But do you find that yourself, for people well, I suppose you might get two camps. You get some people who do nothing, and some people who try and do too much. Is that the other kind of thing that you'll see?
Yeah, I always say that I only see people that do too much or too little. The people in the middle, I don't see.
Okay, yeah. Okay, yeah.
And that's typical in most people, is that they'll either overdo it or underdo it. And the great thing about obviously what you do, James, is that you're always trying to instill health in people rather than trying to just build people up to be as strong as they can and no pain, no gain. And that's works really well, because I can have a chat with one of your clients and just say, look, you're doing this at the moment. Maybe if we tweak it, you'll be able to carry on with your PT sessions, your classes, and you won't lose the overall strength. We just need to back off from this one area. And tendon problems often occur through training in the gym because they're very strong. They can withstand a lot. And it's not until you've been consistently overloading it for a period of time that you start to feel tendon pain. And that's one of the things that I work with some of your clients often, is just adjusting the load rather than resting completely, waiting for the pain to go completely. I try to say, well, how about we just either drop the weight, change the exercise, add more assistance. So if it's like a pull-up, you have a stronger band. And then with tendons, you can often use eccentric loading or negative loading to load the tendon in a way that it can get stronger, but without causing further discomfort. So yeah, I don't think rest is ever a good long-term strategy. But unfortunately, that was something that was advised years ago for back pain, and it would feed into all other injuries and all other problems. Is you would have like 4 to 6 weeks bed rest if you had like severe back pain, whereas now the advice is, when you've got a back injury, keep moving, do what you can comfortably, and then gradually do more. So the trouble is that we've become overly reliant on medical support, and now it's being ripped from under our feet without the understanding and education of how to do it ourselves. So I would say that the NHS is trying to educate people, but the horse has bolted in a way, in that over years and years since the NHS was founded, people become more and more reliant on being fixed. And now people can't get fixed. It's like, what do you do? So I try to take away all of that information to my private practice to show people how to fix themselves, how to keep moving with pain, how to overcome and become more resilient, rather than just rest and lay on the treatment table for 6 weeks.
It's very hard. I mean, it's very hard that, I mean, we all discuss it quite frequently, is that we give advice to people, and then the actual taking the action to do it is often not there. I mean, we've probably all worked with people who've had a kind of cortisol injection or something like that, which does appear to solve the problem. But you also know in the back of your head that probably a course of very focused movement practice in, like a shoulder issue, it could be internal external rotation work, or it could be, it could be something to do with a hamstring, with a knee problem. You know that there's probably a route to success that doesn't involve a chemical or intervention or a surgical intervention. But as you said, people are kind of conditioned to seek an external solution to a behavioral problem, because this external solution is a very quick method. I mean, an injection literally takes less than 5 minutes once they've kind of put the alcohol swab on you, boom, done. And you're probably going to feel it very quickly. So do you often get people who come in and just say, "Oh, just fix me,"
You do get that occasionally. But I'd say, because my approach has been always try and be proactive and try and show people what they can do, the people that want to be fixed probably go and see somebody else. And that's been really good for me, because I've seen the people I wanted to see. But at the same time, there's people that are sitting on the fence. So people don't know whether they need to be fixed or whether there's something they can do. And often, if you show people what they can do and they actually believe in it, then they will start to take those steps to make the changes. But there's always times where physio doesn't work and treatment doesn't work exercise doesn't work, and that's where you still need to rely on the medical approach. So I refer people for injections, I refer people for MRIs. You might need to send people on to surgery, but I think all we need to do is try to become less reliant on it when it's not needed, understand how to manage conditions yourself, and also be stronger and be fitter so that when you do have an issue, it doesn't impact you as much.
I find that, like, the idea, what you're talking about, because tendonitis is a hugely common problem, isn't it? So I find it really interesting because I didn't used to know this before I, got into the world of health and fitness and all that. I didn't know, that maybe you're going down the gym and then like one day you go down there and then your tendon starts to hurt and you're like, what did I do on that one occasion that made my tendon hurt?
Yeah.
It's like, it's not, it's what you've done on every other occasion that you've been down there. And it doesn't even need to be in the gym. It can be something you're doing at home. And then people are like, right, what have I done? What have I done here? And it's like, you've done it over a number of years. So it's being like, in my head, it's being sort of aware of movement and how to move and all of that. The other thing the question I've got though, is how do you deal with, so I fell over in January and hurt my ribs here. My foot went under me. I actually landed on a kettlebell. Very stereotypical, that, isn't it, of me? I was just like wandering around with the kettlebell. But I slipped over and landed on it. But I did that like 11 years ago, snowboarding, same thing. And I had shoulder problems for about 5 years afterwards. And as soon as I fell over, it just straight away, my head just went, boom, I'm going to have all those problems again. Like I couldn't believe how fast I thought of that. And then I immediately thought after that as well, I was like, no, that's not true, because I know what I'm doing these days. And I didn't then. So how do you deal with that with people? Because obviously you can't say to people, it's all in your head. Pain is all in your head. It's not in the area, all of that sort of stuff. So how do you kind of, I suppose you have to convince people that they can get better, don't you? That the pain will eventually go away. Because anything that they do to hurt it immediately brings back memories, and memories of, for me, it was starting to bring back memories of like 5 years of being in pain, and I didn't want that again, So how do you kind of, do you deal with that? It sounds like you do.
Maybe Dave can talk about, Dave, we mentioned the name, the client that you train who always talks about his bad back.
Yeah.
It's a similar thing, isn't it? He's kind of almost in his head. He's thinking, oh, I'm going to hurt my back. I'm going to hurt my back.
Just keep thinking that's going to hurt my back. So therefore it does, doesn't it?
Yeah, he's an amazing case study, because he when he first came to see me in another clinic, he was used to treatment and didn't really look after himself too well. He weighed about 6 or 7 kilos more than he does now. He probably expected treatment at the time, and I did treat him, but I suggested that maybe if we go to the gym, we might be able to manage all of the problems, because he said, I've got a shoulder issue, a back issue, I've got a hip issue, a knee issue. And I was thinking, well, I've got half an hour. I don't think I can.
Which one do you want me to look at?
And I was thinking in my head, you clearly need some kind of regular exercise. You need a different approach. And we started probably 4 years ago, before the pandemic. And he's changed so much in that time, in the sense of, when a problem occurs, he's very analytical. He wants to work out what the problem is, but he also wants to know what to do. But beforehand, he was overly protective and overly worried about what it was. Whereas now, he still worries, but you can sort of snap him out of it and say, okay, well, let's just do this instead. Let's do that instead. Try not to talk about it too much. And it's only because I know him so well that I can be a little bit more flippant with him. But when you've got someone new through the door that is being overprotective of their joint, you just have to guide them and take it slow. And that person has their parents talking to them, their grandparents' information, their great-grandparents. So this isn't just something that they've suddenly become fearful of. This is something that they've known for a long time. It's better to be careful. It's better to protect. And it's impossible to change someone in a day. It's impossible probably to change someone in a year. So some people, you just have to sort of help them in that moment, give them a little bit of information. Hopefully that feeds into them over time. And often people then start to realize, okay, maybe this pain isn't damage. This pain is because I've done too much that day. And then they start to change the behavior. But it really depends on the person. Some people are so willing to accept anything you say, and some people are so against accepting anything else other than what they believe.
Yeah, it's that. I think you're. I think, have you seen Susanna recently about her wrist or something, or
her elbow? Yes,
her elbow. Yeah, because she was in yesterday, and it's just kind of like you say, because she was doing the pure strength session, and all we've started doing is, instead of her doing those banded chin ups now, she's doing like a TRX row, for 10 reps, which is a lot lower load, a lot more controlled, a lot more. She's doing that, and in between all the exercises last night, she was just doing kind of exercises that you'd obviously given her, so she's a great example of someone who's taken the advice that you've given them. She's not stopped exercise, but she's slightly adapted it, and she's kind of working in some of the kind of rehab type movements that you've given her within the session, and it seems to be working really, really well. So I think because your approach, I know we've spoke about it a lot, and I know early on you kind of said that there is this kind of school of thought, I suppose, with therapists, and I don't know if it's people just because it's good for business and for making money, but this kind of people building dependency upon you doing something to them on the couch, and cracking them and massaging them and doing stuff where it's very much like Pete said earlier, you're fixing them and they just come and see you. And I know that you said very, very early on that you want to spend as little time as you can in the therapy room with them, and you want to actually come out with them into the gym environment and get them moving and show them how to kind of heal themselves, and better improve themselves. I mean, is that it's difficult to tell, because I don't have masses of experience with sort of osteopathy and physiotherapy and chiropractic and all the different therapeutic kind of modalities and things, but is that quite a common approach now to actually get people out and moving as quickly as you can? Or is there still this kind of, I'm doing this treatment to you on the couch? What's the, you see what I'm saying? Is it moving away from that now?
I would say that the education system is changed so that it's much more about teaching people to look after themselves. And then each individual that is the therapist, depending on, if it doesn't really matter if you're a physio, osteo, chiro, massage therapist, they will have their own belief system. And if they truly believe that they are healing you or fixing you, then they will be pushing that approach and that narrative. And for me, because I was talking about the injury I had as a child, there was one occasion where I aggravated my Achilles. I think I was 8 or 9. My football manager said, I'll do this stretch. So I did this stretch, and I remember being in my bedroom, just putting my hands against the wall, stretching my Achilles. And that was the first time I thought, oh, well, there's something I can do. Later down the line, I had an MCL strain, and the physio told me, I'll put a knee brace on so you can play the cup final. So I put the knee brace on, but became reliant on it for probably a year. And anytime I took my knee brace off, my knee would feel unstable. So that was me becoming dependent on something. And that was how I started to think, well, that wasn't very effective. Like, that didn't help me. So now I always think, right, try and give people as little to depend on and be more independent, and then build that into your rehab, build that into your day-to-day lives. But you're always going to have people that won't be able to take that on. They won't be able to take on the advice, and they still need the treatment. So I wouldn't say it's bad to treat people physically, hands-on. But as long as you're giving them guidance to say, right, this is helping your pain and this is helping you move better. But if you don't do something yourself, the likelihood is it's going to come back. It might come back a little bit more of a it will become more of a bigger issue later on if you don't become independent in your management.
I think that's good, because that's really kind of empowering people to take. We speak about this all the time on the podcast, empowering someone to take more responsibility for themselves. And you mentioned, didn't you, about the broader point of the NHS. Lots of people became very, very dependent upon it, and now that it's stretched and it's harder to access, they don't really have any strategies or any kind of awareness or knowledge themselves to look after themselves. And then that's where it becomes a problem. So I think that kind of self-empowerment, self-responsibility is a massive thing. And we talk about that on this podcast, across lots of different areas, but it fits in perfectly with this injury rehab, without a doubt. Yeah. In terms of your training, what do you, because you still play football, don't you now? Yeah. How are you finding training? And I mean, what do you do for yourself? I mean, how old are you now, Dave?
35.
35, because people might not be able to see you. They might be listening, you see, they might not know how old you are. But so as a sort of a 35-year-old physiotherapist who still plays, competitive football as well, what does your kind of training and your self-care look like for yourself? How are you different now with the way you approach your fitness and training and sport now at 35 than you were when you were 25?
I would say that the only difference really is that where I would just, maybe when I was in my early 20s, would just continually play through a problem. Now I try and manage it, because when I was early 20s, I didn't really think about longevity. I just thought about getting back out on the pitch, playing as much as I could. Whereas now I think if I want to be playing football in the next 5 or 10 years, I need to manage these problems well now so that they're not a problem later on. And even that isn't going too well, because my knee has been painful for the last year and it's impacted me quite a lot. But that's just football, and you're 35, so you can't do as much as you used to. You just have to manage. So
scares the hell out of me when my clients play football. Because I just know, I mean, they come in with all kinds of injuries. I mean, even my trainer, Frantisek, he used to be semi-professional, came in yesterday limping, not able to straighten his leg because he played football. And he's a good player, It's just like middle-aged MMA, isn't
it? You see, that's why pressing the way I do is fine, because I don't limp.
It's interesting, though, because we do all have to adapt. And I think, like you say, it's what we spoke about this a couple of weeks back, where we sort of said as you get older, and I mean all the three of us are all in our kind of mid-40s, so we're kind of a decade older than you. You have to take more care, don't you? You have to think more, I think you said, when we spoke about injuries, it depends how old you are, because the older you are, the longer it potentially is going to take for tissue to heal and to improve these things. So I think that kind of having that more longevity mindset, certainly in your 30s and then your 40s and your 50s, has to take precedence over a kind of performance mindset in a way. I mean, do you find that from people that you treat and that you train?
Yeah, I think you can't be comparing yourself to 20. But what you did, who was it with the other day? I think it was Yana. You was talking to her about her weight category and what she was performing at that level, and maybe that age range. And if you allow people to see those stats, then that allows them to be competitive. For me, I'm playing football with people that are in their early 20s and sometimes in their teens, and it's just completely unfair.
Yeah, I can't.
Excuses ready.
Exactly.
I can't remember what there's a quote, isn't there? Well, there's a lot of stuff around, comparison, kind of, the basic the pitfalls of kind of comparing yourself to others, And I think that, comparing yourself to others, or who you were 5 years ago, or 10 years ago, or 15 years ago, or 20 years ago. I mean, we see a lot, obviously, people come into the gym who are maybe in their 50s or 60s, and the first time you meet them, they're kind of telling you about what they used to do when they were in their 20s. Well, I used to be able to do this. I used to be able to do this. I used to lift this, and you're like, well,
Used to have hair.
Yeah.
that was Dan John, wasn't it? I used to coulda.
Yeah, used to, woulda, coulda, shoulda, whatever it was. Yeah. But
you're not thinking of that R&B artist, woulda, coulda, shoulda.
Yeah.
I don't know any.
It was the whole, you see this me who's walked in here now, that's not me. This is me now. What I am is me 20 years ago. It's like, no, you're not. Sure.
Yeah, yeah. And people who maybe say, they're in their 50s and 60s and they're talking about what they used to do in their 20s, but they haven't done anything for the last 30 years, and they kind of, in their head, they think, I should still be able to do what I did when I was in the gym when I was in my 20s. It's it's fascinating. It's fascinating. Dear me. Oh, well, Dave, thanks so much for coming on and talking. It's been we might have to have you on again, actually, and talk about something a bit more specific. I think today was almost like a bit of an intro to you, and so people get to know you, and it's been really interesting because, like I say, I never knew anything about the whole Great Ormond Street sort of area and what you did there, and the insights you got from that, which was fantastic. I know you've got a patient coming in to see you soon, so we'll start to wrap up. Pete, have you got any questions or any comments before we kind of?
I haven't not specific to anything that we've just spoke about or anything, but it was Dave, thanks for coming on. I agree, we should get you back on because we've kind of skirted around a lot of stuff, I think, haven't we? So, but yeah, just a quick story of one of the guys who actually had to have a varicose vein out, talking about putting you on the table and fixing you. He had to have a varicose vein out. And apparently, the doctor, the surgeon lady, said, like, "Do you mind if I put some music on while I do the procedure?" And he's like, "No, that's fine." So she put Coldplay "Fix You" on repeat. He was lying there. He doesn't like Coldplay for a start, but he's lying there like, really? Are you kidding me?
You've got to have your own soundtrack these days, haven't you?
I know, but
Instagram post.
Yeah, I'm going to say, she either really liked the song or it was kind of subliminal messaging, as he was laying there. Yeah. Anyway, Paul, anything you'd like to say as we conclude?
No, I always find it fascinating talking to people who fix physios and people like that, because basically my entire journey has been trying to solve one problem after another with my body. So it's always interesting to get your insight.
Yeah, no, that's great. And Dave, if people want to find out more about, Principle Physiotherapy and, follow what you do and social media, that sort of thing, or if they happen to be, local to Essex and things and might want to actually see you in person, what's the best way for people to kind of follow you and to get in touch?
So the easiest way to book an appointment if they're local is to go on our website. So that's principlephysiotherapy.co.uk. So it's PLE is principle. And you can follow us on Instagram or Facebook, and that's at Principle Physio. And again, that's PLE in principle. So yeah, that's probably the best ways. And obviously our contact details are on the website as well if they wanted to call us.
Excellent. No, and like I say, maybe we'll do another one down the line. We can pick like a specific, common injury, common issue that people have, and we can maybe discuss something. Because, like I say, it's been a good overview and a good kind of people to meet you. But we can maybe, discuss something more specific and go more in depth next time. But no, that was really good. So thanks so much for coming on, Dave. It's been brilliant.
No, thank you all for bringing me on. It's really nice to meet you, Paul and Peter. And James, obviously, I see you every day, so nice to see you again.
Well, you might see Peter and Paul again at some stage down at Results or something, I'm sure. But yeah, so thank you very much for listening, everyone at home. Thank you for listening. Please do like, share, subscribe, leave a review if you're watching or listening on a platform that allows you to do so. And if you're on Instagram, if you're on Facebook, please do give us a follow or give us a like. on the social media platforms. And if you are on YouTube, please do subscribe and click the notification bell, because that helps us get out there to more people. We will see you next week, who I believe we have Karen Smith on next week from Texas in the United States. So we've got another couple of weeks of guests lined up. So we will be back next week with another guest. And as I say, think Karen Smith. So we'll catch up with you soon. Thanks, guys. Take care and see you next week.